Hi there, everybody. Welcome to the session on cognitive communication disorders. I am really happy to be able to welcome our elite level speakers today. For your information, we have a slight change to the programming, and Dr. Nicholas Ben and Anna will be speaking first, followed by Hajira Mumtaz and Madeline Farrow. And then, fingers crossed, Professor Leanne Toa will be joining us towards the end of the session. I'm sure that you have all seen this many times by now, but for those of us who are joining just for this session, just direct you to the housekeeping document that is shared there. Questions into the Q&A box, please, and that way we don't have a Q&A for this session. However, if we have time, then we will try and answer what we can. If not, then our speakers will get to those at the end. If you want to chat, make comments, please feel free. We welcome all of those. And just to be aware that the sessions are recorded so that you can watch them at a later date. Feedback is always welcome, and as I'm sure you know by now, we do have the secret code popping up at the end of this session. So without further ado, I would really like to welcome Dr. Nicholas Ben and his cohort Anna, talking about rehabilitation treatment, the specification system, and how it can inform the development of voice and brain injury SLT interventions. So take it away, please, Nick.
Thanks very much, Jerry. I'm just going to share my screen so people can kind of see this briefly. I'm assuming you can see that fine. Perfect. Okay, so thank you for getting us to talk about the rehabilitation treatment specification system. I'm going to be presenting this with Dr. Anna White and another co-author, Brian Kendi, who couldn't be here today. The main aim today is to talk about the RTSS and how we may be able to use this as a framework to look at speech and language therapy interventions and look at them in terms of their development and their evaluation. And what we're going to do today is actually look at them through the lens of both brain injury and voice interventions. So give you a bit of background about the RTSS, or the Rehab Treatment Specification System. We employed this system to describe the interventions utilised in various literature. This system is underpinned by treatment theory, helps us to understand how and why a treatment works, to essentially unlock what we call the black box of what intervention, of what rehabilitation involves. It's broken down into three main components. Basically, the ingredients. So this is what the clinician does, or what they select to do in the treatment sessions. So this could be modeling or role play. It then has the mechanisms of action, and this is how these ingredients are theorized to bring about a change. So how is this treatment expected to work? And then it has targets. So this is the aspect of function directly targeted for change. And these form a tripartite treatment component. There is another component known as an aim. So this is kind of, I guess, goes beyond the target and is the overall aim of the intervention that you're doing. Now we think about using the RTSS, you can see this direction of causality. So we do something in the treatment, and it may be a role play or a demonstration or give an instruction, and it may bring about a change using various processes and brings about change in that target. But when it comes to actually thinking about interventions and describing them and kind of developing them, we usually start with either the aim or the target and work our ways backwards to the ingredients. And I guess one other thing to talk about would be just to reflect on the target for a moment. So the targets can be broken up into three different types of targets. You have organ functions, and this is where they target the function of an organ or body part. So this might be something like muscle strength, for example. You have skills and habit targets. So this is where you're targeting the ability to perform a task or habit. So in voice interventions, it might be like pitch range. In brain injury, it might be the use of a communication strategy. And then you have representations. And this is about targeting someone's underlying attitudes or knowledge about a certain behavior. So what we're going to do now is kind of walk you through a number of different interventions from voice and brain injury to show you how we've applied and thought about the use of the RTSS. So I'm going to pass over to Dr. Anna White now.
Thanks very much, Nick. And I first of all have to just acknowledge my terrible voice today on account of having COVID. So I'm very, it's kind of ironic that I am talking about it from a voice point of view with definitely not a good voice myself. So the first study we wanted to talk about is one that Brian Sasenti Kennedy and his colleagues used with the RTSS within a systematic review that was looking at voice therapy in the aging voice, or in presbyphonia as it's termed. Thanks, Nick. So this topic was of interest due to the high prevalence of voice disorders in those aged over 65 and the growing older population. Now, the most common cause of voice problems in older adults is age-related changes to the larynx and to the respiratory system. And the first line of treatment is voice therapy. So although voice therapists have been treating the aging voice for decades, greater evidence was required to understand the most effective treatment options, and Brian and his colleagues therefore wanted to undertake a systematic review and meta-analysis of the literature, which would offer practical information to clinicians in practice. So Brian carried out a systematic search of the evidence and whittled down over 2,500 abstracts to 23 studies which met the eligibility criteria. Now, for each of these studies, they extracted information about the target of the intervention and the clinician delivered ingredients. This resulted in an extensive and complex matrix of potential targets, but they were able to divide them up into these three categories that Nick had talked about. So the organ functions, skills and habits, and then the representations. They considered a range of outcome measures and analysed these according to a number of factors, but including which type of RTSS treatment category had been used. Thanks, Nick. And then from this, the RTSS was able to help them analyse the findings. So one example of how the RTS helped was when Brian and his team considered maximum phonation time, i.e. how long an individual could sustain an R sound. And what they found was that there was a mean increase of 5 seconds when this outcome was considered in all of the studies, but there was a high level of variability. And analysis using the RTSS helped to show that those interventions which worked specifically on organ functions had a much greater impact on maximum phonation time than those which worked on skills and habits. So in summary, using the RTSS allowed them to analyse quite complex and variable findings in much greater detail, and to tentatively conclude that the treatments working on organ functions may better address some aspects of the ageing voice. Thanks, Nick.
Now I'm going to present on some intervention development that's been informed by RTSS in brain injury. The Tango study is exploring communication partner training, which helps to educate and train family members, friends, carers of people with brain injury. This study is using the RTSS combined with behaviour change theory to help design a program theory for the delivery of training by SLTs to people with brain injury and their family members. So we've coded evidence-based manuals, we've completed a 3-round Delphi to create a program theory that is comprised these aims, these targets, these mechanisms and ingredients, which are all key components of the RTSS. So I'm going to show you the program theory, which is comprise all of these components. So if we start with the aim of this is we want to have improved conversations, more positive emotions, better relationships. The target is to have improved strategy use in conversation. This is underpinned by 5 components of training. They could be considered steps or sub-targets that need to be met to achieve the target of improved strategy use. So these are related to attitude, confidence, motivation and goal setting, skills and independence. Under each of these and actually what I should say first is that you can see here we have representation targets which relate to changes in attitude, and skills and habits targets because it's related to improved strategy use. Under each of these sub-targets are a series of mechanisms of action, which are in yellow. And the circle numbers give you an idea of the number of therapist techniques or ingredients that we have identified that need to be involved in bringing about a change in that sub-target. And these ingredients have shown to have strong links with those mechanisms to achieve the sub-target. We have then used co-design involving SLTs, people with brain injury, and family members to adapt the intervention. Here you can see pictures of the techniques they considered on the left-hand side, so choose targets, problem solving, and how they grouped what they considered to be either core or optional techniques when considering the sub-target. Here, it's about a change in attitude. And in this way, the RTSS terminology, combined with behavior change theory, has been able to be used to co-design what would be considered a very complex behavioral intervention. I'm going to pass on to Anna, who's now going to talk about intervention development and testing with respect to voice interventions.
Thanks, Nick. Yeah, so this next example shows how the RTSS was applied to a voice therapy intervention for patients undergoing surgery on their vocal folds. So the RTSS was used to inform the development of an intervention for pre- and post-operative voice therapy. This project was a multi-phase study, and the RTSS was used in the final stages of intervention development and then in feasibility testing. So the development of the intervention was helped by two frameworks. Initially, the TIDIA checklist helped to specify some aspects of the intervention, such as why, how, and who provided the intervention. And this was a really useful start, but we still lack specific detail on the question of what pre- and post-operative voice therapy should comprise. And this is where the RTSS voice came in very, very helpfully. Next slide, please. So by using an international electronic Delphi study, we were able to gain consensus on some targets and ingredients that a best practice pre- and post-operative voice therapy can comprise. And so this intervention, named the PAPOV intervention, ended up with 7 essential components, which you can see here listed on the slide, that would be delivered to participants at some point during their treatment. Then there were also 4 additional components that clinicians would apply as appropriate depending on the patient's needs. Now, each component can be broken down as described more fully in this brief example. So we have that overall aim that Nick was talking about, and then here the target is to increase the patient's knowledge about their diagnosis, prognosis, and treatment plan, which could be applied to any kind of clinical area. The ingredients in this instance are to provide information, and that can be done in a range of different ways. And then we can also consider how we can measure this and specify information regarding the dosing and the timing related to this component. Thanks, Nick. So having completed the intervention development work, in 2023 we opened a non-randomised feasibility trial with an embedded process evaluation. So feasibility outcomes included things around recruitment, attrition, and completion of outcomes, whilst the process evaluation looked in greater detail at treatment fidelity, adherence, and acceptability. And it's here that it was really useful to have such a thorough description of the intervention based on the RTSS terminology. Thanks, Nick. So we were able to use the clinical notes and videos of sessions to identify the treatment components that were used in each session and to see which of the essential and additional components were included for each participant. Furthermore, we could analyse the timing of that inclusion and then gather views from participants about each of the components. We were also able to gather information from clinicians about their views on the RTSS. And although none of the clinicians in the trial were familiar with the RTSS prior to the trial, they all felt that this was a really helpful, practical, and useful way of structuring their interventions and thinking a little bit more about what they're doing and why with patients. Thanks, Nick.
The last one we're going to look at is looking at how the RTSS has been used to describe interventions, in this case in brain injury. So project-based intervention, this is an intervention which supports people with brain injury to engage in meaningful activity to create a tangible end product, like a video or pamphlet, with its intention to benefit others. So through a literature review, we identified a number of studies that focused on project-based intervention and then mapped those studies to the RTSS and the 4 individual components that we discussed earlier. This process helped us to understand the complexity of this intervention, but also how they are expected to help people change from this intervention. We identified multiple aims, as you can see here, that can arise from being engaged in a project. We ended up with a list of targets, and I'll show you this to you in bigger form in a moment, and a number of different ingredients, both associated with the 4 aims. The mechanisms of action were largely unspecified, but we've theorized as to which mechanisms we feel may be the processes in which change occurs. So learning by doing, cognitive and affective processing, but you can see others around knowledge, self-awareness, and group processes. And we anticipate that this thematic framework can be used a bit like a menu of elements to consider when designing a project-based intervention for people with acquired brain injury. Here you can see the 4 aims of the projects and lists of targets that a clinician may work towards. The 4th column refers to targets from running a project as a group. So you can see that if you're running projects on an individual basis, you'd probably just be looking at the first 3 columns. You can see how a project could achieve many different aims and many targets, but it's important for the clinician to be clear, focused as to exactly what they're trying to target to ensure that the therapy achieves exactly what the client wants. Here, you can see what the clinician may do to achieve each of the individual aims. Again, this is to be used flexibly as a guide to help clinicians consider what may be most important for them to do in a clinical session when working towards a specific aim. So in this sense, a project may work on multiple aims, may have multiple targets, may have most likely going to have multiple ingredients as well. And so you use this to kind of guide that process. I guess the reason all this research has been done and why we're interested in RTSS is because we want to know more about how is it treatments work and why. And the RTSS provides us a framework to help explain this by enhancing our description of interventions, which helps clinicians be able to deliver those in practice. I realize we've given you a lot of information all at once, and I'll show you our emails in a moment, and there's journal papers associated with all of these projects, but it gives you an idea of how RTS can be used across multiple clinical populations that SLTs may be involved in. And certainly for those of you that are clinicians in the room, is starting to think about how do you define the interventions and things that you do with your patients, and starting to think about it in terms of these 4 components. What are the aims? What are the targets, and being a bit more specific about what that target is, how do you expect that target to be achieved through which techniques or ingredients it is that you do. This framework helps us to understand how to replicate these interventions in practice, but also helps us to understand as researchers what components may or may not work when delivering interventions and in what combination. Thank you.
Thank you so much. Thank you so much, Nick and Anna. That was really informative, and I think it's really interesting for us to see how different backdrops or theoretical backdrops can be applied across the spectrum of speech and language therapy, and to see such 2 vastly different areas being represented is really, really important. I now have the pleasure of introducing Maddie Farrow and Hajira Mumtaz, and they are going to speak to us. Oh, are they there?
Hello.
Thank you. Hi there. So, and they are going to speak to us on their operative assessment tool. And I'm going to let them talk about it because I will just fumble over those words. So welcome, Madeline and Hajira.
Hello, thank you.
We have you both on mute still.
Yeah, can you hear us? Yeah, I have to share this file. Yeah. Let us know when you can see our screen.
Oh, brilliant.
Okay, can we start already? Hello everyone, my name is Hajira. I am a PhD candidate at the University of West of England and the South Mid Hospital, Bristol. I work on a collaborative project with the neurosurgical team at South Mid, where we develop language tests for awake brain surgery patients. I have here with me two of my colleagues, Maddie and Molly, who will say a few words about themselves.
Hello, I'm Maddie. I'm a speech and language therapist at South Mid Hospital and I specialise in neuro-oncology.
And I'm Molly. I'm a speech therapist at South Mid Hospital as well, specialising in neurosurgery.
Thank you, Maddie and Molly. Today we will introduce to you guys our test BOTIM. BOTIM refers to the British Object and Action Naming Test that we developed specifically for intraoperative mapping. Over the next few minutes, we will walk you through our motivation for developing this test, the process of its design, and how we demonstrated its clinical application. Over to you, Maddie.
Thank you. So I just thought to give a bit of context, I had to talk briefly about intraoperative language mapping for those of you who don't know about it. So this happens during an awake craniotomy. So that's when brain tumours are resected, but the patient is woken up and is conscious and able to interact. So during this time period, language mapping can take place. And to do that, the surgeon uses a direct electrical stimulation to cortical or subcortical areas of the brain. And the purpose of this is that it temporarily stops the function of that area. And that can last for up to 4 seconds, and any longer with this stimulation runs the risk of seizures. So during this kind of 4-second time period, a clinician, so a speech and language therapist or psychologist, will administer a language test that's been practiced before. If the patient then starts making errors, we know that this is a positive site for speech or language for that patient. So the aim of this awake craniotomy and language mapping is to locate and preserve function to then improve quality of life. But it's also for maximising safe tumour resection, because surgeons tend to be more confident during awake craniotomies than they would be if the patient was asleep. Thanks, Julia. So one of our colleagues at the Brain Language and Behaviour Lab at UE, Sonia Mariotti, ran a survey to find out about what clinicians in the UK were doing in terms of assessment during awake language testing. And she found that most clinicians were using a kind of mix and match approach to language testing. They would either kind of develop their own bespoke tasks, adapt homemade tasks from other speech therapists, use subtests from standardised batteries, or translate tasks from Dutch, from something called the Julep. So this is all kind of because there's a limited availability of tests that are suitable for brain tumour patients, and not a lot of tests available for awake language mapping in particular. Intraoperative tests need to be sensitive enough for the language profile that you see in brain tumour patients, which differs to that you see in stroke and other conditions. But they also require specific criteria to be suitable for the mapping. So as I mentioned, you've got a 4-second time constraint, which means that you need to be able to respond to the test within that time. The tests need to be very easy to use because it's quite a stressful experience. The patient needs to understand very easily what they have to do. And you're also needing to assess critical language functions in a very specific way, depending on which part of the brain you're testing. So thinking of some standardised tests that were found to be being used, the Boston naming test, I found a review by Harry and Crow. That's actually been validated with a 20-second response time. It was found to not detect more subtle language deficits. And it also has some concepts within it that wouldn't be commonly understood by everybody. So there I've got the example of the yoke that I don't think I've ever found anyone name, and the compass, which I struggle with. Another test that's used commonly is the pyramids and palm trees. So here a review by Klein and Buchanan found that's got poor test-retest reliability. So that means that it wouldn't provide a consistent measure of language if it was tested over time with the same person, which might be problematic if we're using it pre-op, intra-op and post-op. It also had low internal consistency, so it's found that the items within the test weren't all necessarily measuring the same thing. So in this case, semantic memory. And then here's a couple of examples of some homemade tests that we were using at Southmead. And this was actually me that found the pictures, so I have to own up to that. So I would just go on Google Images, find some pictures and hope for the best. So I'd end up with a lot of kind of mixed images. And actually a review by Raymond et al. In 2022 found that image features do influence recognition and naming performance in people with neurological deficits. So for example, they found that size and colour will affect the time needed to name an object. Things like texture and shading facilitated naming performance. And even the view of an object can help with picture naming. So for example, if there's a picture of a zebra taken from the side, that's easier to name than an image of a zebra from the front. Action name was also particularly difficult to find a picture that could be interpreted the same by everybody. So here I've got one of the pictures that I used, and that would be, people would say jumping, dancing, and you actually, you need to know for sure that you've got one target action word. And of course, none of these were standardized, and it was difficult to have enough tests within a test battery that I'd made myself, because you're having to find all the images on Google. So you'd run out of tests quite quickly.
So for a more accurate and truthful assessment of the language function, recent evidence suggests the use of standardized tests, as Maddie already pointed out. But these standardized tests should also be linguistically and culturally tailored to the patients. This is because such measures have several benefits. For example, with standardized materials, you have controlled stimuli that have been pre-tested in healthy volunteers, and you can therefore obtain a clear and consistent interpretation of language performance across various clinical scenarios. At the same time, linguistic and cultural specificity of the stimuli matters because such materials reflect how patients use language in their daily life, and they eliminate the influence of any external variable that can influence task performance. So to address the need for a more unified approach for neurosurgical language testing in the NHS, we developed BOTIM. BOTIM is the first standardized and clinically tested picture naming tool that is addressed specifically to British native speakers. We built BOTIM from the ground up, unlike all the unstandardized and homemade stimuli that Maddie pointed out, where items are either borrowed or made within institutions. What BOTIM offers is a large set of picture stimuli that represents object and action naming concepts. And one of the many unique features of BOTIM is that it has data, it has stimuli that have been linguistically and culturally tailored to native British speakers. We ensured this relevance by basing our materials on the British National Corpus, which essentially is a huge collection of recorded speech data from native British speakers all over the UK. We took an extensive approach to develop BOTIM materials. This started with the selection of concepts from the British National Corpus. We then filtered these selected words according to a strict criteria. So for example, if a word was difficult to represent, that was excluded, to visually depict was excluded. We then gave this large pool of words to native British speakers to score them for various linguistic variables that we know from the literature would impact a person's ability to recall a word or a concept. We then created images and then controlled these images for image-related psycholinguistic variables. So, for example, we ensured that all images were visually uniform in terms of the amount of surface details or the content that is represented on them. We then standardized these images with native British speakers in 2 steps. And then finally, we tested these materials in real intraoperative settings with brain tumor patients. To standardize BOTIM stimuli, we tested 54 healthy volunteers. These were participants who reported no history of any underlying neurological condition that could impact their ability to use language in everyday settings. Participants named BOTIM stimuli in a short sentence context within time constraints of 4 seconds. Here's an example of how the stimulus presentation was done. With this testing, we identified 115 object images and 86 action images that were named consistently correctly by over 80% of our participants, and we considered this as our final material for the BOTIM test. We looked at some trends in participants' performance at this stage, and as expected, naming objects was easier than naming actions, and as a result, we excluded a lot of action stimuli, significantly more action stimuli compared to objects. We also tested the suitability of our materials for participants of various ages and educational background, and we didn't find any impact of these variables, which led us to conclude that our tests are suitable for participants of various demographics. To assess whether BOTIM is a consistent measure of language ability over time, you must have remembered Maddie mentioning test retest reliability. So we invited a subset of our participants from the standardization stage a year after their initial participation and re-administered the test, and we found excellent correlations in their scores across the 2 time points. And finally, we also looked at whether the concepts we have chosen, whether their linguistic properties had any impact on participants' task performance, and we found patterns that were in line with the existing evidence, and these were more frequent concepts that were more frequently used and learned early in life were easier to name compared to less frequently used and concepts that are learned later in life. In the light of these results, we can say that BOTIM stimuli provide insight into factors that affect naming of concepts. Yeah, over to Molly.
So in terms of using BOTIM, we've been using it regularly with our patients in awake language mapping. We have increased confidence in the test because we know it's been standardized to a normal population. So we know that our patients should be able to do this unless they have a significant language impairment, and in which case they potentially wouldn't be considered for an awake craniotomy. The materials are relevant and up to date, they're clear, there's less ambiguity in terms of being able to name the items quickly. So that gives the patient confidence as well going into surgery. And also the large battery of items means that there's less repetition in surgery. It keeps it interesting rather than having to kind of repeat batteries over and over it, say during the resection phase of surgery. And then just an example of its use with a patient. So we used BOTIM with a 15-year-old boy who was bilingual. He had a left temporal tumour in the superior temporal gyrus. He presented with focal seizures, which were characterised by temporary aphasia followed by dysphasia, which was also temporary. And preoperatively, he had a mild reduction in verbal fluency in English and a moderate reduction in Polish. Those were tested with the CAT. We used the BOTIM tests for both object and action naming in both English and Polish with an interpreter. And we also used it to develop a language switching task, which meant that we could test the patient's ability to switch between the 2 languages online rather than testing all English and then all Polish, which would be more reflective of natural language use. Interoperatively, we found object naming errors in the language switching task when using BOTEM. So that tells us that there was a positive language site in the superior temporal gyrus, and we gleaned that using BOTEM. Back to Hajira.
So to conclude, we would like to add that BOTEM is our first attempt towards developing standardized and clinically tested tools for neurosurgical language testing, but we don't want to stop here. The long-term goal is to use this rigorous framework we've adopted for BOTEM to design tests that address more complex aspects of language, because as we all know, we don't in our daily life just go around naming concepts. A key direction for us in this regard is to design tests that address functional language use, because that is more meaningful and relevant to the patients. As practical directions, steps that we're taking in this regard, we are currently piloting tests that assess larger linguistic units, so for example, phrase level or sentence level processing, and we hope to expand these tests to further more complex designs. BOTEM is a freely available open access resource, and we invite you to access the materials, use them, or distribute them amongst your clinical community, because yeah, we think it's a really robustly designed test, and it's a very good test. So please get in touch or ask questions, or if you would like to know more about BOTEM. Thank you very much for your attention, and if you have any questions, we would be happy to answer them.
Thank you very much. That was really interesting, Hajira and Maddie. We do actually have time for questions, which is excellent. So just to let all of you know, unfortunately, Leanne is not able to join us. We do have a video of her presentation that will be available online after this. So you will be able to come back in and watch her presentation. I just wanted to take a moment to really congratulate Hajira and her team, because I think creating a new standardized tool is such a remarkable achievement, and particularly given, you know, the difficulties in getting anything published these days. So I think that you should be really congratulated, and to have something that is so specific to the British population is really quite an amazing feat. So really well done. I'm sure the rest of the audience would agree on that. We are happy to take, we've got about 7 minutes for questions, and we're happy to take questions for both Maddie and her team and Dr. Nicholas and Anna White. So I will go to the questions now. And I think there was one just quickly for you, Hajira and Maddie, around, first of all, your decision-making around choosing line drawings over photos, and what prompted that decision-making.
So we did, thank you very much, by the way, for your kind words. It really is encouraging to PhD students who spend hours writing manuscripts and materials. About the line drawings, we actually conducted a pilot study, which at the moment I'm hoping to finalize and submit for publication. And we selected 3 different formats of images and tested it with a group of healthy participants to see which image format or type would be most suitable for testing during a 4-second time constraint. And it turned out that color drawings were, I mean, there's evidence already in the literature that they that color drawings are, as Maddie also hinted upon, that color drawings have a benefit. They have positive. There's more positive towards how they influence performance, but they haven't been compared with the image types that we had in mind, and it turned out that they were the winner. So that led us to guided us towards choosing them as our format, and then we went through an extensive process to actually test them on various stages, and yeah, that's how we selected them.
And I think in clinical experience, we were just talking today about some of the images, for example, in the comprehensive aphasia test, and I'm finding myself having to explain, oh, this person here with this hat is the soldier. This is the female because she's got a bit of a ponytail, and it's, yeah, you shouldn't really be using images that need explanation. A bit of colour and shading is great.
Excellent, thank you. Another question that's popping up is, and you may not be able to answer this, but and maybe there's people who can add to this in the chat, but what are the opportunities for shadowing in this area? Because I think it's an area that a lot of speech and language therapists are particularly interested in, but perhaps don't get the opportunity to see or to shadow in. What's your understanding or knowledge of that?
I don't know if there are any guidelines about it. We kind of make sure that there are some kind of learning objectives aligned with someone shadowing in an awake surgery, because obviously the patient is awake, so there has to be a purpose to it. But yeah, I kind of ask anyone who's keen to shadow that they come up with a set of relevant learning objectives, and that's okay.
I think that's certainly fair enough. And another question that has popped up in the chat there is around how, and I think you've already touched on this in one of your previous answers, that actually many of our assessments have quite challenging visual imagery, and whether or not you would consider releasing this for more general language assessment.
To new languages?
Well, just for other clinical groups, I guess. Yeah.
That's one of our long-term goal as well, to expand the stimuli to make it a battery which would be comparable to something like comprehensive aphasia test or Boston naming. But of course, as we all know, the images that are used there, or even concepts, they're sometimes really outdated, and yeah, as we talked about earlier as well. So we potentially we would expand the project to include much more complex stimuli, and make it a battery that is applicable to patients of various etiologies. So
yeah, I guess at the moment it's only been validated with brain tumor patients, but it could be validated with others in the future.
I'm sure we will wait with bated breath for that validation as well. And then one of the most popular questions that we've had is about whether or not you would expand the recruitment to other sites, or you know, have other sites were they included in the trials? Whether you would expand recruiting other sites so that they could increase the data, you could increase the data set.
Other scientists.
So other hospitals.
We're currently using it at NBT, but we presented it at various at a symposium, awake craniology symposium, which was attended by various neurosurgical members across the country. So we're hoping, we've had requests for access, and also I recently presented it at the British Neurological Society of Surgeons conference, and a lot of people were interested. So we have had requests for materials, so we're hoping that they're using it, and yeah, we still have to do a follow-up collection of some sort of responses to see how many centers are using it, or whether they're willing to share their data with us, but that would potentially be a side project. But we are collecting these, we're interested in collecting these numbers. When you scan the QR code, we get information on where the center is and stuff. So, but we're yet to confirm it's actually being used or people are acquiring materials. But yeah, we hope that they will share the data is good for the generalizability of results.
Excellent. I think that's the fact that you've made it a free resource as well, I think is, yeah, a very, very kind and generous strategy. I think that might be our time for this session. So apologies again that Liam wasn't able to join us. As I said before, that video will be available for you all to watch once the session closes. But a great big thank you to Dr. Nicholas Ben, to Dr. Anna White, Maddie Farrow, and Hajira Mumtaz for their wonderful presentations. Lots of questions there. So anything that we haven't answered today will be answered subsequently, and you'll be able to access those. Thank you all very much.
Thank you.
Thank
Thanks.
you.
Thank you.